Okay, so hopefully some have signed on. We're really lucky to have Sophia Hufnagel come and talk about controversies in genetics. We thought this would be a really nice discussion on how to, on disclosure to incidental findings in whole exome sequencing. So thanks so much for coming.
Thanks for having me.
And we're looking forward to hearing.
Sure. So just a little more about me in terms of my background. So I'm Sophia Hufnagel. I'm a geneticist here at Children's National. I did my training at Cincinnati Children's, and prior to that went to GW for med school. And in addition to my interest in genetics and fetal medicine, I'm also really enthusiastic about ethics. I studied philosophy in college, specifically virtue ethics, and have founded multiple biomedical ethics groups throughout my various levels of training and currently serve as an executive ethics committee member here. So today I'll talk with you a little about a specific controversy in genetic medicine, of which there's many, which is the disclosure of incidental findings in a test called whole exome sequencing. So I have no disclosures. So I thought I would just start with a quick story. So a few years ago, I met a 27-year-old young woman who had recently been diagnosed with cancer with hereditary implications. Her only presenting symptom was uncontrolled pruritus or itching, and had gone years without pursuing an extensive workup, chalking it up to like allergies or eczema. She was eventually diagnosed after finding a supraclavicular lump, after which she shared that she was haunted by the question, what if I had known sooner? I mean, I was itching for years. Why didn't I push to figure out why earlier? And although I'll never know when it started, whether or not the cancer definitely correlates to the itching, whether or not it would have changed my management course or outcome, I still want to know when, I want to know why, where was I when that first cell went bad? How would it have changed my path? So if it were possible that she would someday know that her risk of cancer, would she really have benefited? And she really want to know? And if so, when? At what age would she have benefited from that information? I share with you this story to best emphasize the underlying question that brought me into this kind of research, which is, when life-changing challenges occur, might preparing oneself for such events help ease the shock or aid in management, or is, quote, blissful ignorance prior to knowing the best path? So a few aims to describe our history of the debate, a discussion of the pros and cons, and then the future direction. So Huntington disease is the classic example used, which is super helpful in conceptualizing the ethical considerations. When the test for Huntington disease, which was one of the first predictive genetic testing tests in clinical practice, was developed, a consensus was formed among researchers, physicians, patients, and their families that predictive testing should not be performed on asymptomatic minors. Over time, though, over the last 3 or 4 decades, let me just put everything up. Oops. Over the last 3 or 4 decades, the battle between the risks and benefits result disclosure in minors has led to an increase in empirical studies with the goal of clarifying the ethical responsibilities of the clinician. So in a review of the literature by Mand et al. In 2012, who collected arguments for and against the predictive genetic testing of minors for adult onset conditions, they analyzed the evolution of the debate since the onset of the discussion. They note that earlier in the debate, clinicians tended to be more conservative in their testing of minors, with few arguments describing any potential benefit. But in comparison, a more flexible patient-centered involvement has evolved over time as a result of a more balanced nature of arguments for and against predictive testing. So I use Huntington disease as an example, but keep in mind that Huntington disease is a result of damaging triplet repeats, which is actually not picked up on whole exome sequencing. With time, though, as our technology improves, more inclusive, comprehensive testing will emerge. Therefore, I still think it's a great analogy to use. So in clinic, let's move back. In clinic, as geneticists, we see patients. We pick out distinct clinical features in conjunction with an exam, medical history, family history, and create a gene panel to assess for potential etiologies. Now, though, with whole exome sequencing, rather than testing a single gene or panel of genes, whole exome can analyze the majority of known coding regions, and it works via a data filtering system based on the clinical features documented by the referring clinician. because it has the potential to identify variants in genes that are not associated with the phenotype that prompted the initial test. A debate surrounding predictive genetic testing on pre-symptomatic individuals has blossomed yet again, just the same as it has for Huntington disease. So although pre-symptomatic individuals can present at any age, I personally am more interested in the testing of fetuses, minors, and children, and in testing of conditions that are not medically actionable in childhood. So I'm just going to kind of further emphasize this definition because I'm going to use it a lot throughout the discussion. There's a lot of different ethical considerations based on medically actionable versus non-actionable. So a medically non-actionable incidental finding is an unanticipated finding unrelated to the initial indication for the testing that may put a patient at risk for a genetic condition in their future, but does not currently have medical interventions, prevention, or screening options available. So now let's move and talk about the current debate. So in 2013, the American College of Medical Genetics and Genomics initial policy on clinical whole exome sequencing stated that medically actionable, so these are conditions that there are interventions that exist, these incidental findings should be sought and returned irrespective of patients' preferences or age. Some examples include familial adenomatous polyposis, long QT syndrome, Wilson's disease. These are things that there are interventions and they are in childhood. They can potentially present in childhood. So with respect to age, the ACMG argued that parents might otherwise be unaware of their child's risk and that this information can be indirectly beneficial to their health. But this has also led to a lot of controversy. Much of the attention focused on adults who wanted to have the ability to decline these incidental findings, and eventually the recommendations were revised, and now there is something called an opt-out or opt-in policy, depending on the lab you use. You have to specifically be counseled separately, though, in order to get these incidental findings reported. So, even despite all of that, less attention has been paid on prenatal testing or the testing in minors in general. One of the criticisms of the ACMG's policy is that it was developed without taking the stakeholders' involvement, which are the minors in my personal interest. So now let's talk about the arguments for and against predictive testing found in the literature over the last 3 or 4 decades. I split the categories, I split the pros and cons into 4 categories to help us understand the arguments. And also let me just say here that I do not necessarily endorse one side or another. I'm simply stating what's currently in the literature and in a hopefully unbiased manner. So with the cons. Psychological harm for the individual is the first category. A positive test can result in a negative impact on one's self-esteem, self-image, may increase an individual's anxiety or depression, perhaps an increase in suicide risk. Testing may induce feelings of guilt and or blame, or even survivor's guilt if one's testing returns negative while a family member's returns positive. There's often a surrounding stigma associated with having a genetic condition that some would just prefer to avoid. It is possible that symptoms that are not due to the condition may be misattributed to an early manifestation of the disorder, leading to frequent unneeded medical attention. There's often difficulty in interpretation of ambiguous results due to variants of uncertain significance that have not yet been identified in the literature or difficult to attribute to pathogenicity. If there's no current treatment, some argue there's no benefit in knowing. There are some authors that argue that the prefrontal cortex, the area involved in decision-making and inhibition, doesn't fully mature until our early 20s, therefore argue that minors are ill-equipped to making irreversible life decisions, such as those surrounding predictive genetic testing. The next category is negative effect on family. This is especially true if the relationship if a certain family member doesn't want to get testing while another one does. Testing in minors may disclose information about a fetus or sibling status, given that many disorders have a known inheritance pattern. Positive result may lead to a modification of parental expectations, or what we sometimes call as vulnerable child syndrome, in which a parent may continue to baby a minor into early adolescence and limit discipline and can lead to difficulties in that way. If family dynamic is poor, those children may be at a disadvantage due to lack of support, and this also may limit one's personal family planning decisions.
What do you mean by the last sentence?
For example, if I know that I have an autosomal dominant condition, I may choose not to have a child because of the 50-50 risk. It may limit what they would have done, what they may have done if they didn't know about it. Autonomy. Testing minors fails to respect their future autonomy for when they are adults, breaches their confidentiality. And then social discrimination and limitations. Some are concerned by the potential discriminations related to their insurance, peers, employers, or even in education. This is despite the GINA Act. A positive result may result in an individual's life choices. One may choose not to become a physician due to the prolonged schooling, for example. And even further, there's a disproportionate representation of Caucasians of higher socioeconomic status who have undergone these predictive testing, and the data surrounding their preference cannot necessarily be extrapolated to the general population. So now let's move to the arguments for predictive testing in minors. And I want you to notice that many of these arguments are mirrored, in which some authors find a benefit while others seem harm. The same would be true in our patients. So the psychological benefit for the individual, this can decrease anxiety, uncertainty, depression for the individual by ending what we call the diagnostic odyssey, or the grueling long pursuit of testing to find some answer. Testing can have a positive effect on an individual's identity, self-image, self-esteem. Some become leaders in a specific genetic disorder. Support groups give motivational speeches, for example. Some authors note minimal evidence of negative psychological consequences. So in a study by Wade et al. In 2010, he did a systematic review exploring the impact of carrier and predictive genetic testing on children's psychosocial well-being, which he defined as emotional state, self-perception, or social health. And in children's ages 8 to 18, they tested for Fragile X syndrome carrier status, familial adenomatous polyposis, and Huntington disease. They report that this was not in the U.S., by the way, this was in Australia. They report that the overwhelming majority of the results did not reveal a significant negative effect on children's emotional states, whether the results were indicative of a risk or not. So the concerns surrounding anxiety, depression, suicide, or any of those assumed mindsets that were reported by ethicists earlier on in the debate were not found to be statistically significant in this particular cohort. And then further, some argue that cognitive capacity, or the formal operations thinking in Piagetian developmental terms, generally develops around age 11 and is well developed by age 14. So in a study examining competence to consent in medical treatment, 14-year-olds showed comparable levels of competence to the corresponding adult groups. So you're already starting to see the mirrored arguments. Testing can have a positive effect. It can strengthen relationships if the dynamics in the family are good. Testing may promote realistic parental expectations in their child. So now that they understand what the condition is, they can move forward. Testing can provide insight into potential options for a child's reproductive future, such as having time to mentally prepare for the possibility of having a birth of a child with a genetic condition, providing options in assisted reproductive technology or prenatal diagnosis, or avoiding a pregnancy altogether if that's what they choose. So autonomy. Many argue that with proper consent, parents are the ones that are best placed to decide what's in their child's best interest. And it is important for us to avoid medical paternalism. Adolescents have been shown to be capable of making informed conditions about their health already, such as with sexual health, via Planned Parenthood, for example, in which parents' input is not required. So some argue that they are able to make other medical decisions for themselves as well. In fellowship, one of my research projects was to determine whether or not adolescents ages 11 to 18, given this list of pros and cons at an age-appropriate level, would prefer disclosure of incidental findings that aren't actionable for them in childhood, And we found that 83% preferred to know, despite their age, and most of whom cited planning for their future as their reasoning. That specific number, the low 80s, is exactly what the parents have been shown in the literature to also. So they matched their parents in terms of preference.
Were these children that were facing a disease?
No, this was hypothetical. Hypothetical in the general population classrooms I did it in Cincinnati. Testing may promote an adolescent's autonomy due to early mental adaptations of a disorder, and being able to adapt to the information as a result of discussion within a family or with physicians over many years at different stages of maturity can help provide them with tools to make more informed decisions as adults. Knowing can empower them as individuals to be more active participants in their health. Preventing harm. So newborn screening has been conceptually similar to predictive genetic testing in minors in that it has helped prevent significant morbidity and mortality in countless cases. In comparison, the views of the AAP in disclosure of chronic illnesses such as HIV or cancer status in a minor has been supportive. They cite that it improves self-esteem, ensures the child learns in a positive environment, and promotes the child's growing role in the healthcare process. Thus, some authors argue that it may be easier to deal with traumatic news as a child than as an adult, as many things that they learn are equally new, and this would just be one more new thing they'd learn about themselves. Non-disclosure can lead to feelings of deceit and abandonment, or imply the unintentional message that the disease is so dangerous that it should not be discussed in the family or with their physician. An example one author used was with adoption, in which there's an increased feelings of deceit if the child is not told they're adopted before age of 10. And some think there is harm in not disclosing results because they might miss out on evolving therapeutic interventions, even if there's no current treatment. So as technological advances improve, we will likely be confronted with these issues in the prenatal setting more and more, especially with our increasing knowledge of more conditions. We need to be prepared with these cases and understanding the vast spectrum of pros and cons for asymptomatic prenatal testing to best guide our patients in an unbiased way. That's it. Thank you for your time, and I welcome any comments or questions.
That was very good.
Thanks.
Questions? I wonder if anyone from Innova is on. Is anyone on the line from Innova?
So I know Innova is doing the whole exome study. Whole genome study on prenatal cases. I don't know a lot of what they've found so far, but whole genome in general throughout the world is essentially very difficult to interpret. I think it's more of a data collection at this point, is my understanding of what they're doing.
Yeah, I would just be interested to get their input because they're actually involved in this.
Boston's also doing a similar type of study. I think Boston Children's Road or something.
Cost, did you talk about the cost of the study?
Cost of like doing a whole exome? Yeah, so I didn't talk about that, but some interesting things that kind of a thing that I noticed in our practice in genetics is that we still tend to start with we generally start with a microarray. If we have a patient with a set of symptoms that seem syndromic that we aren't able to fully identify, we'll start with the microarray, and then if that comes back negative, then we'll move towards specific gene panels. But after you do 1 or even 2 gene panels, it just becomes more cost-effective to do a whole exome at that point. So there's this balance of what the insurance will cover and focusing in on what the patient's presenting with versus just, shotgunning and doing the whole exome with the knowledge that other conditions might be found that are unrelated to the patient's condition. So I do find that a lot of my colleagues, after 1 and sometimes 2 panels, it depends on the patient. I tend to do 1 or 2 as well. We'll just move to exome if the patient is truly seemingly syndromic. And even with them, sometimes we don't find anything,
right.
you know, not yet, at least.
Can you give us an estimate of what a panel costs versus?
It really depends on that. You guys might know better than me, actually. I mean, it can be like $6,000 to as much as like $30,000. And insurance will cover any variability of it. It can be zero, they can cover nothing, or they can cover 80% or 100% depending on where you send it or what insurance they have.
It's really variable.
Super variable, yeah.
And how much is a microarray?
They're like 4,000, I think. 3,000. Yeah.
So what do you guys think? Pros or cons? I mean, I think this is part of, and I'm just going to shoot off the hip, but I think this is part of this whole sort of brave new world thing where our concepts of so many things, sexuality, race, everything seems to be in flux at the moment. And I'm wondering whether the same thing is going to happen with disease, where we stop saying there's a binary condition, you're sick or you're not sick with regard to a specific condition, and that it's going to become more of a continuum, and that disease is going to become sort of relative, and the difference between and our way of seeing people that we're going to die sooner or suffer more. I mean, if you think about the whole Alzheimer's thing, for example, and how we're having to wrestle with that, and how we currently fail to include those people into our concept of what is normal. I bet that this issue is headed in the same direction, so that, I mean, we all see this as, oh my God, this person's going to be tagged as destined for Huntington's disease. Yeah. Whereas I bet in future, I don't know, maybe I just have too much confidence in the human spirit, but I bet in future these things are going to happen. People are going to be doing this type of work, and that people will grow within that diagnosis what is considered a normal life for that diagnosis. And I know I'm going off here, but
no, I think you bring up a good point. I think the thing that comes to mind is the biggest red flag with these kinds of prenatal exomes are the variants of uncertain significance. A woman making a decision in terms of termination or not based on a variant that is really just poorly defined, or a condition that is indicative of risk but isn't 100% indicative of risk. So, you know, this % risk of having this particular condition.
So maybe uncertainty will be part of that, the sort of soup of life, you know.
I think so much of it, though, right now is about the informed consent process. I mean, I think the issue of informed consent is the biggest one. Most of the doctors who are sending these, not genetic stuff, but in rural areas where there aren't people who are helpful with families, are just sending them off, and the families they don't understand what they're getting before they get the test, and they don't understand the results, nor do the physicians have the time. It's not their fault. It's just that that's not what they know. And unfortunately, many of the labs, even the good ones, aren't helping that scenario. I mean, they accept any sample they get. I mean, if they get $30,000 for the sample, they're going to run it. They're not going to say, did your patient have proper counseling and this and that? So I think here at Children's, we have a protocol where we have to counsel these families before they get the testing. They have to come in, and that's like an hour of counseling to make sure they really understand what they're getting into. And then they have to come back for the counseling as well. They can't just get it on the phone, even if it's negative, to really understand what does the negative mean, what does the positive mean. But we have that luxury. We have all these genetic counselors here. We have, you know, that luxury of that protocol here. And I think that's unique to the country, whereas so many other places.
But I think that's just more of a reflection of how the regulation can't get its arms around it. off at the moment because we don't really, we're wrestling with it. It's sort of in that murky leading edge.
Yeah.
But I think I think the problem is, depending on what diagnosis you're looking at, it's very nebulous. But, you know, I just went through a colleague with Huntington's, and it was really terrible here. The father finally, after 50 years, realized he may have it. Now the son is planning on becoming pregnant. So does he want to know, not know, you know? And there's no right or wrong, and, you know, some part of the family doesn't want to know, others
It's
maybe.
the perfect example of
So
this.
it is a perfect example. I think the Alzheimer's is almost a little bit different because there are some promising medications out there that they're now talking about maybe giving it, you know, if you're at risk. So for that, at least in the next 10, 20 years, there may be some things you can do with that information. But the Huntington.
But if we want to develop drugs that'll arrest the disease, and we never know it in its pre-disease state, how are we going to be able
I'm just saying for the individual person, I still kind of think Alzheimer's might be a little more nebulous because it's a little more of a spectrum. But Huntington's, it's just so black and white and terrifying.
What did you guys think of the pros? I mean, when I first heard about this debate, I was like, oh, definitely don't test minors. It was just my gut reaction. But then as I read more and more about the pros of testing, I was like, oh, wow, there are really some. I still don't know what I would do or what I would encourage for my own children or my patients, or probably just lay it out like I have. But I didn't realize all of the potential benefits in knowing early. And I didn't realize how much literature shows that kids do want to know this information, you know, whether it means that there's a way to treat or not. I don't know. I thought that was interesting.
Yeah. And also the age at which kids can really make a good decision about this. I mean, having a 13-year-old at the moment, the decisions that she makes are not, I think, the things that she's going to choose when she's 18 and 20, and it would worry me, honestly, as a parent to say.
And every child's different, right?
Right. I mean, every child is different. Certainly, there's probably some that have the decision-making capabilities at that age, but, like, you just can't imagine.
Did you touch on high sensitivity disease?
In what way? And
just for testing, and so if a family member has it.
Well, that one can present in childhood. So that one, if a patient is symptomatic, we would test.
Right. And then they talk about, you know, being on a diet. Or so it might help. Yeah. The focus was more my particular interest. Well, there's so many levels of the debate. You can talk about every kind of result, but I was so interested in the ones that I have no actionability prior to age 18. I just think that one is so conceptually interesting. Like Huntington disease, but in other ways, Alzheimer's is a good one. Even breast cancer, ovarian cancer, the earliest known cases has been 18. So that's another good one. You know, you find an incidental finding on a 2-year-old that has a BRCA gene. That can be very traumatic news for a family who already is getting an exome for some other condition, you know.
So what that example does, I mean, which is slightly different than the Huntington's example, is that it does make it medically actionable for a parent. Because that means that one of the parents likely passed it on.
Right.
So, whereas Huntington's, like, even if you found that on a 2-year-old, you're not going to do anything.
Right. No.
So that's where the informed consent comes in. Is these families have to know that it's not just about the 2-year-old, it's also about finding information out on them.
And I always, it's exactly right. And I always tell all of my patients who are reluctant to do testing, why should I do this? Like we get that actually pretty often. And I always say there's 3 benefits to testing, depending on the family. One is prognosis. It might give us insight into how you do later in life, based on what the literature says about this condition. 2, it can give us insight into management and treatment. It can, if we know what the condition is, we know what to look for, we know how to help you, how to guide you through the condition. It can be a form of preventative medicine. If I know the condition's associated with a particular, like thyroid disease, I know to go look for that, even if patient isn't presenting with it. And then lastly is chance for recurrence. For if and when you want more kids, or your child wants children, or it helps you understand the whole family tree. It gives us insight in the inheritance pattern. So
And if a cure is found for whatever your disease is, we know where to find you.
Yeah, we know where. And, you know, a lot of patients ask about clinical trials. I think that comes up at least weekly, if not more often. And they want to know. They are very interested in support groups. They know, honestly, some patients know more than I do about what's currently going on in the support group world. And I learn a lot from them because of that, you know, because they do see it they take this bad news and they turn it into an empowering bit about who they are, and they make it part of who they are, not who they are, but they make it part of who they are, and they move forward and they help the field. And if it weren't for some of our families, some of these conditions would not be as far along in terms of research. They fundraise and they help so much, you know. We all have patients that in every field, not even in genetics, who, you know, really take that diagnosis and raise so much money and help the field, awareness and all that other stuff. ALS challenge, for example, how much money did that raise? It was amazing. That ice bucket, it's amazing.
Very easy. He went to DC.
Yeah. So, I mean, there's just lots of, it just is very interesting debate, and there's no right or wrong answer, and every patient will believe one thing one day, and then the next day, maybe not so much. Even that 27-year-old patient, she wanted to know so badly at that moment, but a few years later, who knows what she would have said. You know, you can't ever know, hindsight's 20/20, you can never know. You know, she just was stuck in the moment of, why didn't I push earlier? I had the symptom, why didn't I do more about it?
I was relieved to find that I'm not the only crazy one, because I was sitting just this morning. It was around the cathedral there at one of the red lights. And I was just thinking, and I thought to myself, I wonder if before this light turns green, a cancer somewhere in my body is going to reach the point of no return. It's going to reach the point of no return. You know, I mean, how many cell divisions have to go wrong after which? Maybe before the light turns green, I'll be committed to a different path.
Well, and then hopefully some other cells will destroy that cell. You know, it probably happens all the time.
But
in all of us.
when is the battle going to be lost?
I don't know. I know. I hear you. And what makes one patient more susceptible? No, I've thought about it too. Yeah. But anyway, it also goes back to a lot of like the philosophical discussions. You know, how are we all so the same and so different at the same time? And what makes up a person, and how can we all be human but have such variability?
But I think it can, you know, depending on the person, for some people it can just consume them. And,
you're right.
And that becomes
I do have one more slide,
so,
in case somebody brought this up, but it was the actual predictive testing rates based on compared to the hypothetical expectation. So when actually faced with testing, patients who were at risk for breast and ovarian cancer, whether they got the testing or not, it was actually about less than 60%. We're actually getting the testing. And then versus Huntington's disease, do you see that range there? 20 to 88% based on, there's been countless studies out there that have asked this question, and some patients say yes, definitely up to 88%, and then some as low as 20%. Some of the characteristics of dropout were if you were closer to the age of onset of the condition. So if you were closer to the age of Huntington's disease onset, then you were more likely to drop out. Versus if you were younger, you were more likely to just get the testing done. And if you were married, you were less likely to do it, but having children didn't seem to make a difference based on those studies.
So if you're married,
you were more likely to drop out. But if you had children, it didn't seem to make a difference. I know, I thought that part was interesting.
And then the older you are, the less you want to know because it's just closer.
Yeah. Isn't that interesting? Based on these studies, there's,
And breast and ovarian cancer, was it like a 10% risk? You know, like what was the, do you remember?
That's a good question. I don't remember the number.
But I guess it kind of makes sense because, you know, if you've made it to 50, whether you get it or not, you're not going to change your life anymore. You've already done what you've done. So you probably don't really want to know and just about it. While if you're younger, say, okay, should I get married? Should I have kids? Should I do this?
And this is a little different, too, because these are known condition inheritance and patterns. Right. So both of these are 50% versus an incidental finding, which actually the catch rate for an incidental finding is 0.89 to 5% of actually finding a condition on that incidental finding panel. So knowing that that risk is so much lower may have patients may be more likely to get it, thinking it will affect them less, versus these conditions, it's a huge 50% is a much bigger number.
I always think about the person in the lab that finds the incidental finding, but families have to.
Well, actually, there's a huge debate on that. They don't actually know themselves. They're blinded. No.
Well, some of them, yeah, but like a GDX, a lot of the texts do know.
Really?
Yeah.
They're supposed to filter it out. It's supposed to be one of the filtering mechanisms so that nobody knows. So it's truly unknown.
So the people in the lab are supposed to analyze
the coding region.
The number or whatever.
So the people in the lab don't see actually the name of it.
It's my understanding, but she might know because she knows she has friends that actually work in these labs. But my understanding is that in the filtering process, you filter out genes that are not associated with the set of conditions. You can also filter out the incidental findings list so that nobody knows. It is truly an unknown, because there are so many ethical considerations to knowing that a patient is at risk for something and then not disclosing it, even if they don't want to know. That can be very troublesome for a lot of people. So filtering it out takes away that responsibility for the lab, and the labs don't want that on themselves. That's a huge liability on them. So they should probably not admit that they know that, because that can be a huge deal. You know.
Can you opt back in later?
Yes, any time. Every lab gives you that option. You can opt just in any exome, you can go back to have a second look. You can have a second look and include that incidental finding. But once you know, you know.
Yeah.
So
it's a fascinating new world.
Yeah.
But it's comforting to have people like you who are so comfortable about it.
Yeah, that's amazing. Thank you.
Thank you.
The neuropathology of Down syndrome is not sufficiently characteristic to permit its diagnosis.